Coming up is my interview with Dr. Mariza Snyder. Dr. Mariza is a powerhouse advocate for the midlife woman. She is leveraging her 17 years as a practitioner, but also her own personal experience and really bringing the perimenopause conversation to the table. It's one that we have not spoken about enough. It's a conversation that is so necessary because the truth is that today, education is coming from you. You know what all of these life stages feel like, and you are driving our new healthcare system. So tune into this conversation. It is chock full of information and insight that you're only going to get here. So stay tuned for Dr. Mariza. Well, Dr. Mariza, you look gorgeous, like glowing gorgeous. It's so nice to have you back on the podcast, and I'm really excited for you. You have a new book coming out.
I do. Book number 9, The Perimenopause Revolution. I'm so happy that the perimenopause, the transition is having a moment. It is long overdue. And man, I always say that perimenopause is the zone of opportunity. Because what we do in this beautiful
love
transition.
that.
Yeah. Yes.
You know, it's funny. I trained 30 years ago. Can't even believe. And not only do we not talk about menopause, but we hardly spoke about perimenopause as even, it almost didn't exist as a thing, right?
No.
It was just like something like, oh yeah, whatever, your period is wacko and we'll just either do an ablation or, whatever. But we never talked about what was physiologically happening to people and whether or not they could do anything about it. It was just like, deal with it and deal with the consequences. It's so amazing that we're having this revelation now.
Yes, I know. I think a couple of things happened. Why we didn't recognize it. I remember the narrative that I was brought up with is that women suffer. That was what I was told that was true.
Like periods we were pretty much put on earth in order to do that, right?
Exactly. Women are on this earth to raise children and suffer. That was kind of the underlying. So I think when women really were suffering in their 40s, heading into menopause, we and the symptoms were subjective. We just thought it was all in their heads, for the most part, or that it was just
a rite of passage.
Yeah, or right. Well, and I think all of it was just lumped into menopause. So maybe menopause was not just the one day in time as we kind of define it now, that it was several years. But what ultimately I think, one, we ignored the symptoms unless it was hot flashes and night sweats or low libido or vaginal dryness or maybe even sleep issues. We just wrote you off. We siloed you into specialties. And we kind of just told you, this is just the way it is. It's kind of how it is. And we don't really have a solution until we know you are in menopause. And then we've got Premarin or we've got, something along those lines to keep you feminine forever, I guess you could say. Yeah. And so now we're realizing women are like, you mean this entire transition where things have been so wonky and I don't feel like myself anymore? Like we can define this. It isn't just aging. It isn't just, we don't know what it is. And then I'm in menopause. And so I'm so, so deeply grateful that we're having this conversation. I think the reason why perimenopause is having such a big moment is that women are outraged by the fact that they kept being gaslit and dismissed when they knew something wasn't right with them. And so we have this uproar of millions of women who are like, enough is enough. I'm going to speak into this. I'm going to advocate for myself. I'm going to claim agency. And this is why I wrote the book, The Perimenopause Revolution. It really is a revolution.
Yeah. Tell me, did the reason that obviously you wrote the book because it's information that is desperately needed and needed to get out there, but what inspired it? Was it inspired by personal experience?
Yeah, I love this question. So, two things inspired this. Number one, I had just entered my practice seeing women in midlife. I would say in perimenopause and menopause. I didn't know that my women were in perimenopause at the time. I knew that they had symptoms. I knew that it was related to their hormones. I knew that they were being siloed to the cardiologist and the endocrinologist and the psychiatrist and being put on prescriptions, for, insulin resistance, prediabetes, those types of things. And yet we weren't connecting the dots. So I knew I heard my women, I believed them, but I didn't really understand. This is 2010. This is 2010. We're what, a decade into the Women's Health Initiative. Hormone replacement therapy is not happening at this point unless you've got a very integrative provider who didn't buy into the BS of all the media and is still doing it. But again, few and far between.
Yeah, they
So
were few and far
few and far
between.
between. Yeah, like no one I knew.
No?
So my mom is 48 years old. She had me when she was 18 years old. So she's 48, and I'm 30 in practice. And my mom, this woman was always resilient, strong, on top of everything. I mean, she was a single mother. She was always able to have capacity and resilience. That's how I always saw my mom, was this really strong, incredible woman that was able to take on the world if she needed to. And then at around 46, 47, I mean, she had been dealing with fatigue issues. She had been dealing with weight gain. A lot of those, again, women suffer. I think she even thought that was what was happening. She's like, okay, this is just what happens to us as we get older. But then came the crime scene periods. Then came the rage. Then came the mood swings and her not feeling like herself and the sleep issues and the cacophony of so many of the symptoms that women in perimenopause. And all of a sudden, my mom, not only did she not feel like herself, but she was barely holding it all together. And I knew that something wasn't right. So I got a front row seat to my mom going through what I would consider late perimenopause at that point. We were not,
Yeah.
no one was buying into her early perimenopausal symptoms, but the late perimenopausal symptoms were impossible to miss, and they were disrupting every aspect of my mother's life. And that's when I knew that there was something that we had been missing this whole time. And as I got to step into her care, because it kept on being poorly mismanaged, I got that front row seat, and I realized, I'm like, we have got to shift the conversation. We have got to support women in a better way before they get to official menopause. I mean, she was still another 4 years out before she actually reached menopause at that point. And I remember two things thinking. One, like, this is not my mother. She needs a different level of support. And number two, I thought, oh my God, is this going to happen to me? And so when
Yeah.
perimenopause hit me, my mom had me at 18. I didn't have my son until I was 41 years old. And I would say a good solid 2 years in postpartum. I was breastfeeding my son when I started to finally climb out of that postpartum journey. And I had a good solid 5 months where I felt really good. Like, I was like, okay, I'm back in the game. I'm 42 years old, almost 43, and I'm feeling more resilient again. I'm sleeping again. And then about 5 months into kind of recovering from postpartum, I started experiencing some pretty serious symptoms: sleep issues, mood swings, rage. I started to experience low energy, and it all kind of started adding up all at once. And something I tell a lot of my patients and also the community at large is that so often many of us are coming into perimenopause with other stuff. It's rare that we are a full clean bill of health heading into peri. For me, I have Hashimoto's thyroiditis. I had experienced burnout before, so I kind of knew what that flavor was. And so initially, I didn't know it was perimenopause. I thought I was having a Hashimoto's flare. I thought maybe I was burning out. I was working too hard. I was overextending myself. I remember trying to figure out what was going on with me. I felt very blindsided by my perimenopausal symptoms. And I do believe a lot of us, it's a yes and. Like, when those hormones begin to falter, that protective shield that had been keeping things at bay all of a sudden begins to disappear. And things that either we were managing or we didn't know about starts to come up and present itself. So it comes up for review. And that's basically, it took me about 5 months to figure it out that I was officially in perimenopause. And I'm embarrassed to admit that, because I've watched so many women through the journey, and it's so interesting. You can support so many women through the journey, but then when it begins to happen to you, you can feel blindsided by it. I was not prepared. but I was 43, about to be 44. I mean, do the math. It made sense.
Yeah, of course. And I also think, as someone who had children later on, that changes your timeline. And
Yes.
and I think those people tend to go through it a little earlier.
Yeah.
But
Yeah, and I
I
think my mom probably was going through peri 43, 44. If I could, we go
Yeah,
backwards.
it
She
makes
and I have
sense.
dissected this so much. And she's like, yeah,
Yeah.
if the worst of my symptoms were 47, a lot of the things I kept brushing off because no one was helping me anyway. And that was what society kept telling me, was that, oh, this is just what it feels like to be 40. This is just what it feels like to be a woman who's working and managing a family. And she's like, no, it was earlier, it was early perimenopause. I just didn't know until
Yeah.
it got so bad that it was impossible for me to ignore.
Well, we normalize what we don't understand,
Yeah,
right?
yeah, absolutely.
And since the Women's Health Initiative, which, I came out of training in 2003.
Yeah, right
So
after, like literally the
all I
year. Yeah.
all I knew, all that was drilled into my head was the quote unquote learnings of the Women's Health Initiative, right?
Mhm.
So in 2003, I was taught to believe that hormones cause breast cancer. The only women who should take hormones are those that absolutely positively cannot live without them. And said women should take the least amount for the shortest period of time,
Okay.
right? Like that was my understanding. And since then, we've had 2 decades of providers completely untrained in hormones. They don't know what they do. They don't know how to prescribe them. And you used a quote, you said protective shield.
Mhm.
And because of this narrative that we have all been fed, providers and patients alike, that estrogen is toxic, that estrogen is the problem, because of this narrative, no one learned that
No.
estrogen is your protective shield.
Yeah,
No one learned
no.
that, right? That your hormones were your protective shield, and that your hormones are not out there to give you breast cancer.
No. Or any cancer for that
Or
matter.
any cancer, right? Or
Yes.
any cancer, because they're not just protective against breast cancer. They're protective against colon cancer. They're
Yes.
protective against a number of cancers,
Mhm.
right? They are your protective shield.
Absolutely.
And when
Particularly
you lose it, you lose
cardiovascular.
your health in
Yeah.
general. Yeah.
Yeah.
Talk about all of the systems that are affected, because it goes way beyond your reproductive tract.
100%. And this is such an important through line for the book. I want women to understand and be able to connect the dots between their symptoms and their hormones beginning to decline. So I think about estrogen and progesterone as neuromodulators, as immune system modulators, bone remodelers. They are helping to regulate muscle protein synthesis. So the gut is impacted, your muscles impacted, your bones are impacted, your genital urinary system is going to be impacted. I think it's like up to 95% of women are going to have GSM symptoms as estrogen after estrogen declines. But more
What does that
importantly,
stand for?
genital urinary symptoms of
Yeah.
menopause. Mhm.
Yeah.
And most importantly, the brain. I just want to spend a little bit of time with that because when I think about who is the CEO of a woman's brain, it is estrogen, estradiol specifically.
Yeah.
And as estrogen begins to decline, think of estrogen if she's your CEO and she has consistently, rhythmically showed up in the brain to help with neuro regeneration, reducing neuroinflammation, driving energy metabolism and glucose regulation. I mean, it's so much more neurogenesis. And so we have this hormone who for 25, 35 years,
And
every day,
thermoregulation,
yeah,
right?
thermoregulation, absolutely. Hot flashes and night sweats. It's just brain
Hmm.
related. And also impacting neurotransmitters and the sleep centers and circadian rhythm optimization. All of this is estrogen. So she shows up every day, every month, 9 to 6. So that's the CEO's job. And then all of a sudden, she doesn't show up at 9 o'clock in the morning one day. She shows up at 1 p.m. And instead, she leaves at 2 o'clock. And then the next day, she shows up at midnight. and then she goes home at 8 a.m. the next day. And so this inconsistency, the brain is like, what is going on? Like pining. It's like, you know, you the boyfriend or the girlfriend who's ghosting you and you're pining after them. That is the brain when it comes to the erratic loss of estrogen. And as a result, 80% of perimenopausal symptoms are going to be brain related, including the hot flashes and night sweats, including the sleep issues, whether it's you're having a hard time going to sleep or you're having late night wakings, your energy metabolism. So you'll notice cognitive is your cognitive functions being impacted, your memory, your alertness, your mental energy, your lack of word recall, mood swings, rage, ADHD, anxiety, depression. I mean, all of that. I mean, when women say they don't feel like themselves, it's the brain that they're like, wait, why am I not sharp? I used to feel stable. I used to feel on edge. I used to feel like I was high functioning. And now I don't know what's going on. Is this early dementia? What's happening with my moods? Why am I snapping at my family? And that is a decline or erratic decline in estrogen, and also progesterone is playing a role here as well.
Yeah.
So those
Yeah.
are some of the biggest symptoms or systems of the body that are impacted. Also, our metabolic system, body composition changes. Every woman will tell you as they move through perimenopause, something is happening with their metabolism. They're like, what is going on? We're less insulin sensitive because of estrogen declining, and so all of this is shifting and changing. And a lot of it is a silent shift. I think it's important to note. I know women talk a lot about, or we hear a lot about perimenopause being the zone of chaos. But once we're in menopause, it's all going to calm down. I was like, oh, you mean when we're in a low hormone state? That's when it's going to calm down. I was like, what about the silent shifts? What about your cardiovascular risk that shifted? What about the metabolic system that shifted? What about bone and muscles? You know, once we get into menopause, if things were changing in the perimenopause journey, it's not, that low hormone state isn't going to bring those back into like equilibrium or homeostasis or optimized. So I just want women to know that this is very much a continuum. Perimenopause continues into the second half of our lives. There isn't like a definitive stop date where we go from perimenopause, hard stop. Okay, now we're in menopause. No, it just keeps on going. I think it's important for us to know that.
I think that this is the area that is particularly problematic because there are people who do go through this phase, this perimenopause, menopause phase, without being too terribly symptomatic. And those people are lulled into this false sense of security that like menopause isn't bad for them, right? And so they don't realize, and their providers also don't realize, that they're subject to the same deterioration that everyone else is. Just because you're not symptomatic doesn't mean that your cardiovascular system isn't deteriorating, doesn't mean that your bones and joints aren't deteriorating, doesn't mean that your brain function isn't deteriorating. So just because you're not having hot flashes, or maybe you were lucky enough to not gain weight or not have joint pain or not have brain fog, it doesn't mean that the changes aren't happening. They are. They're
Yeah.
happening for everyone. They're
Yeah.
just happening more silently in some people.
Absolutely. Yeah. The second biggest risk factor for Alzheimer's and dementia is being a woman, is being a
Yeah.
women.
Yeah.
It's through
Especially being a
perimenopause into menopause.
menopausal woman.
Yeah, especially I was going to say through perimenopause into menopause.
Yeah.
And what you can't feel that all the time. I mean, a lot of us would say, I was just interviewing a dear friend of mine who's like, I honestly thought I had early dementia because it felt like that. Like everything about my cognitive function began to falter. So I do want to recognize that a lot of women do feel that way, but whether you're symptomatic or not, you know, the research or the stats are clear. You know, although we live longer than men, we spend 20% more of our lives in debilitating health than men. And more women than men are going to die of a heart attack, stroke, or ischemic attack. More women than men are going to have an autoimmune condition. Often, if it hasn't been diagnosed before midlife, it's going to be diagnosed at midlife. More women than men have depression, anxiety, and migraines. More women than men are going to again, dementia and Alzheimer's, 67% are going to be women. And so whether you have symptoms or not in perimenopause, honestly, in a lot of ways, I always think it's a blessing to have these symptoms show up, for everything to really come up for review in this, again, the zone of opportunity, because it's a zone of vulnerability that we could say, okay, actually, this is the body telling me that I need to prioritize me, that I need to shore up my health, that what got me here isn't going to get me to the next level of optimized health. And I need to pivot. And that's what this book is all about, is recognizing the silent shifts. You don't feel your blood pressure creeping, but I can tell you over 60% of my patients will start to experience an increase in blood pressure over their perimenopause journey. You're not going to feel your triglycerides go up. You're not going to feel your liver enzymes go out of range. You're not going to feel, non-alcoholic fatty liver disease. You're not going to feel insulin resistance. But let me tell you, if there was going to be a time where these things begin to shift, not completely into a pathological direction, but shift where we need to know, it's going to be in this journey. It's going to be in perimenopause, not menopause.
Even if the women recognize these shifts, we have a monumental problem in that we have 2 decades of providers who are totally untrained. So even if the women recognized tomorrow that I'm having these things happen and I need help, they have no one to go to. Talk to me about, how did you get educated in this? Because I know that I was not taught this in medical school or residency. Like, I had to learn this all for myself.
Yeah, I told you, when I really began to notice it was in 2010. And I remember saying to myself, like, I have got to be a part of the solution, not the problem. As I saw woman after woman in my clinic, again, her symptoms either being ignored, dismissed, or she was being put on medications, but not addressing the root cause of the problem. And so I just started to dive into everything I could: books, literature, research, interviewing some of the best experts out there. At the time, Dr. Sarah Godfrey was kind of leading the charge with the
Mm-hmm.
hormone cure. And
Yeah.
I think that book came out in 2010, and I just gobbled up everything. She was in the Bay Area along with me at the time. And so that's where I started. I was like, I want to start connecting the dots between the symptoms that my patients are dealing with and their hormones. And
Yeah.
it's been, I think what is it, 15 years since 2010. And so every single day I'm like, okay, how can I understand better what is going on? But even myself, HRT didn't really become a part of the discussion until the last, I would say, 5 years. And even now, we barely have providers and practitioners looking to get educated and looking to understand how to prescribe, or even understand what hormones are actually doing for these women. So
Yeah.
yeah, we have a long ways to go. We are at a really interesting intersection where we have women that know more than their providers and are
Yes.
asking for a new level of support, asking for hormone replacement therapy, and their providers, whether it's their primary doctor or it's their OBGYN, don't feel comfortable prescribing, don't know how to prescribe,
Mm-hmm.
and often will tell women HRT isn't indicated for what they're specifically going through. And
Yeah.
so what we're seeing currently is an outcrop of more, I would say, virtual clinics, virtual practices. And I will say, I'm just grateful that HRT is being offered through companies like MIDI Health or My Alloy. But often what you're going to get when you're working with a, more of a virtual practice, is you're going to get a very cookie cutter static type
Yes.
of dosage.
Yes.
And so, gosh,
And not
yeah.
everyone is eligible in that. I mean, I know they won't even talk to my patients. Like, if
Mhm.
you even have a whisper of high risk for breast cancer or history of breast cancer, they won't prescribe for you.
Yeah. Yeah. We
So,
are, gosh, I get the frustration. I get where, podcasts, conversations like this are happening every single day. And we are advocating for all the tools in the toolbox for women, and not just in menopause, but also in perimenopause. If women are extremely symptomatic due to erratic declining hormones in perimenopause, why are we waiting? Why would we
yeah.
wait, to put women on HRT during a time where symptoms are at their worst? And so, yeah, And then women are going to their doctors, whoever they're near, and they're asking and they're getting denied. I can tell you from personal experience, my primary doctor, my OBGYN, I'm not getting hormones from either of them. It's not even a worthy conversation. I
Yeah.
don't have the conversation with them. I just know
Well,
that
you can't have a conversation with them because
yeah,
they're not educated on hormones.
yeah,
So there's really no conversation to be had. Most of them, like I say, you can't teach the blind to see. Most of them have been trained to believe, and they honestly do, that hormones cause breast cancer. So why would you even entertain the concept? Are you ready for a breast cancer screening revolution? Well, I'm thrilled to introduce to you a breast cancer screening tool that I have only recently learned about, but I have universally adopted. This is the ARIA test. This groundbreaking at-home breast cancer screening test is one that I believe will completely change the game. So imagine a screening test that's as simple as shedding a tear, because that's ARIA. It's a non invasive, convenient, and perfect for all bodies and all breasts. Dense breast implants, no problem. ARIA makes it clear for everyone, even women as young as 30. ARIA is backed by over a decade of clinical trials, thousands of samples, and it's developed alongside top breast health experts. Here's how it works. You collect a tear sample at home, and then ARIA then analyzes it for protein biomarkers that can signal early breast cancer. And the best part, you get a consultation with a breast health specialist to review your results. Now, ARIA isn't replacing breast imaging. I am using it alongside QT. It's complementing it and giving you a fuller picture of your breast health. Knowledge is power, and ARIA is putting that power back in your hands. It's time to take control of your breast health, and ARIA is another way of doing it. Go to aria.care, AURIA.care, and use my code DrJenn20 in capitals, DRJENN20, to get 20% off. Back to our show.
if you tell them you are symptomatic and you think that you're in perimenopause, they're going to be like, okay, well, we have hormonal birth control,
Yeah.
and we're talking about a higher dose of
Which
synthetic
actually does
hormones.
cause breast cancer.
Yes, with the progestins.
Because it is a very dangerous form of progestins, not progesterone, right? And I also think that there are some people, even in the holistic space, that are confusing the landscape because they're putting messaging out there that says that you don't need hormones if you just fix this or fix that, fix your gut, detoxify, do my cleanse, then you won't need hormones. And it actually enrages me because there are people with big voices and big followings, and people are buying into this like, oh, I just need to do this cleanse and I'll be okay. And there is no cleanse that is going to replenish your progesterone, your testosterone, your estrogen. There
Yeah.
is no cleanse.
Well, and I
Right?
do find some of these functional practitioners are men that are having these conversations.
They are men. That's exactly right. And I'm out there
what
like,
do you know?
Are you
What do you
kidding
know?
me? Why don't you step into this body for a moment,
Yeah, real talk.
and then tell me about how you can eat or supplement your way out of this?
It is very damaging. It's very harmful.
Yeah.
And
men have a very different experience.
Oh my
like
gosh,
we
yes.
fall off a cliff.
No, yeah,
That's not happening with men.
No.
Men have, in general, unless they have some kind of inciting incident, men have a slow, steady decline. And even with that, I know a lot of guys on testosterone replacement for low T, right? So I find it particularly infuriating when it's coming from men. But there are some women out there too. I mean, I remember like
It's another kind of gaslighting. It's another
yes,
level of dismissal,
yes,
based on a lack of knowledge and information. And unfortunately, at times, I mean, you're selling your stuff or you're selling your protocols, and so yeah, I mean, I guess to me, I'm like, am I surprised that we're still seeing a level of gaslighting? Not just in
yeah,
the not just in your typical insurance based provider, but also in the world of influencers and practitioners. And yeah, I
yeah,
mean, it's, I call perimenopause and midlife the messy middle. But right now, we are in the messy middle of the messy middle in terms of education.
yes,
And the pendulum
yes,
is swinging all the directions, and so I was just having this conversation with another incredible doctor. We're talking about, how long do we think it's going to take for our providers to be up to speed, for women to get what they need? And, we're talking at least a decade,
Who was the
at least a
doctor? I'm
decade.
curious.
Dr. Darshan Shah with
I love him.
Extend. Yeah. So
Yeah.
he was like, what do you think? How long do you think it's going to take till we get to bedside? And we both agreed it was going to be at least 10 to 15 years.
That's what
And
I
again,
think too.
yeah, not to say that there aren't. I mean, there are absolutely functional and integrative doctors out there who are probably have a waitlist practice. And I don't have an easy solution right now. All I can say is do everything in your power to get what you need, have agency over your health, and advocate like crazy. One
Yeah.
of I don't prescribe myself for my own self, and for the provider that I'm working with is Dr. Felice Gersh out of Orange County, out of Irvine.
I love
And I'll be
Felice.
honest with you, I mean, she's so amazing. She's got a waitlist practice right now as well. And I remember she came in early at 7 a.m. on a Saturday. Mind you, her team isn't there. It's just her in
Yeah.
practice
Yeah.
seeing me at 7 a.m. because that was the time that she had.
Yeah.
And so,
She was just on my podcast a couple of weeks ago,
yeah,
pleading for people to please come work for her and help her. She'll
yeah,
train them, but that's how it is in the world of providers who are hormone literate
hmm,
because there's so and we can, right? We can train people.
yeah,
And it's not
absolutely.
that
And it's going to
hard.
happen.
Yeah.
Yes.
Yeah. And in
So
fact, I've been
yeah.
talking to Lindsay Berkson about
Mm.
starting a provider training course for my own selfish reasons, because even if you are hormone literate, for the most part, you're still afraid of breast cancer,
Yes.
right?
Oh,
Like
yes.
even the
Yeah.
most confident hormone literate provider is like, even if they're prescribing to someone with a history of breast cancer, they are doing it so on the down low. They're
Yeah.
just like quiet as a church mouse doing it
Yeah. I would
instead of
say
being loud
too,
and proud.
besides you, Dr. Corinne Men, who is,
Mhm.
out there. I'm interviewing Dr. Susan Gilbert Lintz today. Again, breast cancer, both are breast cancer survivors who are really trying to dispel the myth that HRT on the back end of breast cancer is going to drive higher mortality or increased breast cancer risk.
Well, in
And
fact, the data says exactly the opposite.
I
The
know,
data
yes.
says that there are better outcomes for women with a
Mhm.
history of breast cancer that take
At the
hormone.
very least, quality of life. Can we, I
Yes.
mean, women, again, this whole narrative that women deserve to suffer needlessly, it's just,
But
I
when
mean,
you
it's
when
so
you think
exhausting.
about it, if all you do is improve quality of life, you are going to improve overall survival,
Absolutely.
because the happier
Absolutely.
you are, the longer you're going to
Yeah.
live,
Yeah,
right?
exactly.
The
Or
longer
the
you
more
want to live,
motivated.
the longer you're going to live.
Exactly. The more motivated you are, the more energy and capacity
Yeah.
you have
Yeah.
to take care of yourself. Absolutely. So yeah, Dr. Susan Lintz and I are going to be getting into this today. But and again, I'm naming off a few, and there are a few, but they're out there and they're very vocal, they're very loud, and they're doing their very best to dispel these myths that HRT is going to drive cancer or drive cancer recurrence,
Yeah.
or is going to
And
drive mortality,
yeah.
rate increase.
Yeah. And I mean, if you
I mean, look
truly
at everyone
understand,
looking to get rid of the black box warning on even vaginal estrogen.
I
Gosh,
know.
the fight to get rid of that black box warning. Oh my goodness.
And it's so
It's just
crazy,
mind
but
blowing.
You have to understand why it's there, right? So the reason that it's there is because the pharmaceutical industry cannot trademark a molecule of nature. And what you and I talk about, and what most people in this space are advocating for, is bioidentical hormone replacement. Because outside of that, though we don't see an increase in breast cancer with the conjugated equine estrogen, we do see an increase in breast cancer with all the progestogens. And that is because the design of the molecule is such that it acts on the ER alpha receptor. The ER alpha receptor is the proliferative receptor. It's the receptor that tells everything to grow. And the more growth stimulation you have, the more likely you are to make a mistake. And so that's where cancer comes from, right? It's an overgrowth state where you make a mistake, and that mistake, which in someone with an intact immune system, that should be recognized in its infancy. But when you lack estrogen, you don't have an intact immune system. And it's not just that, but all the other things that are contributing to immune suppression, because we don't sleep enough, we're not nourished enough, we don't get enough sunshine. The incidence of vitamin D deficiency is astounding. And you put all of this together and you're painting a picture for breast cancer. But it's not because we have too much inherent endogenous estrogen, right? Like, this is not our ovaries sending out too much. It's not our ovaries being bad. And there are certain environmental factors that are absolutely playing a part. There's no question about that. But estradiol, progesterone, testosterone, DHEA, these are not causing breast cancer, but the pharmaceutical industry also cannot sell them, right? They have to change something in order to own those products, in order to patent those products, and in order to profit off of those products. And so they don't want those products on the market. And they would far rather, instead of you being on hormone replacement, they would far rather you be on antidepressants, on sleep medications, on drugs to help you lose weight, on nonsteroidal anti-inflammatories for joint pain. I mean, how many drugs can you name, right? Bisphosphonates for bones. Like, you can probably name 9 or 10 pharmaceuticals that they would rather have you on than you be on hormone replacement.
Yeah, I mean, that's the siloed healthcare that, we're talking about. That when
So
these hormones decline, we start to see shifts in many areas of the body that we have drugs for.
yeah, we've got a drug for that, right? That's their sole purpose, and their voice with the FDA is really loud.
Yeah.
So, I hope that black box warning comes off, but it's every single thing is a really hard fight against a very well-oiled and established machine. And the FDA is not immune to the influences of industry. I mean, they're completely supported by it. They are not an independent branch of government. Yeah. So, what's a girl to do?
What is a girl to do?
Yeah.
There's a lot that we can do. Like I said, it's really about going after, advocating, finding a provider, and it is shifting. It is changing. It is moving in a positive direction. Yes, it feels slow, but there is a lot that we can do. Also, I think it's important to shore up your own health. I mean, despite the fact that we are losing these hormones, there's a lot that we can do. I wouldn't say that they're the end all be all. They're not going to replace hormones, but we can protect our metabolic health. We can optimize our sleep. We can support our circadian rhythm. We can, again, support our gut and our liver health so that we are at least healthy hosts for these hormones. So there's a lot that we can do. As a woman I'm on HRT, I will say that at the end of the day, a lot of what helps me to feel alive is going to be walking throughout my day. It's going to be nourishing foods. I always ask myself, like, what is going to fuel your future brain? And making sure that I'm eating along those lines, balancing blood sugar, having deep connections, having a self-care ritual, whether it's an evening routine or a morning routine that is just specifically for you. Setting boundaries, regulating your nervous system. All of these things are going to help move the needle as well. I wish I could tell you that HRT has been the all game changing strategy for me, but it's really been the lifestyle changes that have made the biggest change in how I feel. And HRT has also been really supportive as well. And so I always want to let you know that it's a yes and that there's a lot that we can do if you're having a hard time getting your hands on hormone replacement therapy. And so I want women to feel hopeful that there's things that they have control over while they're working that whole situation out.
Yeah, I agree with you. And I think that there is another side of the messaging that like hormones are going to fix everything.
Right.
Right.
Yes.
And that's also not correct.
Yes. That's not helpful either.
Right. Right. Like I like that imagery that hormones are the bow on top of the box.
Yes.
Right.
They're the
Inside
optimizers.
of the box are all the things that you can, should, and need to do.
Yes.
Right.
It's a yes and. It absolutely is a yes and.
Yeah.
I wish if I have a woman who's pre-diabetic and she starts estrogen, is that going to reverse her pre-diabetes? No. And so is it going to help maybe motivate her to get into the gym and to move her body in a more meaningful way? Yes. But it's not going to lift the weights for her. It's not going to move her body for her. And so, I always want women to know that it's a part of a more comprehensive plan that we're talking about.
Are there any, for you, are there any contraindications? Is there anyone that you say absolutely not to?
Yeah, I would say, my sister is an example of a contraindication. My sister had a stroke when she was 42 years old. And given her risk, it's just not something we're willing to try at the moment. So I would say incident of stroke and heart attack would be a contraindication for me. Those would be the big ones that I look at when I'm working with somebody or when we're having the conversation.
And I'm just curious. I mean,
and vaginal estrogen, I think is a worthy, for my sister would be a worthy, but like in terms of systemic, I would be. And, the thing about someone like my sister is that there's so much lifestyle that needs to be addressed in terms of how she's living that I don't even think she would feel much better on HRT than if she wasn't. You know what I'm saying?
Yeah.
Like,
there
would need to be a major shift.
Yeah, I have people come to me all the time that think that like this is going to be their solution, right? Mm-hmm. And they're 40 or 50 pounds overweight. Mm-hmm. And, this didn't happen overnight as a result of them going through menopause. Like they've been 40 or 50 pounds overweight for decades, mm-hmm. right? And suddenly they see hormones as the salvation. And I think there has been a lot of like dangle out there, and hormones will answer all your problems. So I do think that there is some gaslighting around that as well. But, that's the person that I say, like, you're not even ready for me yet. Like, mm-hmm. you have so much to get in place first. And that's not to kind of deny them or put the burden back on them. But I find as a provider with hormones, and again, I am talking about a very high risk population, because the people that come to me because no one else will do it for them. Right. And even in that population, I'm not trying to be mean, and I know these women are suffering, but this has to be a partnership, right? And you have to do your part. I'm actually like, I'm really tough because I don't let people drink alcohol. I won't write for them if they're still actively drinking alcohol, because I think that that is a major problem in terms of, if your liver has to metabolize hormones and metabolize alcohol, it's
It's going to
always
choose
going to,
alcohol.
yeah,
Yeah.
it's going to choose alcohol.
Hmm.
And so it's really hard to even manage those women because their levels are not predictable, and
It's,
we really set them up for toxicity.
yeah, I was going to say, we really need to be healthy hosts for HRT. My sister she's diabetic. She's had a stroke. She's overweight, significantly overweight. Like she just
Yeah.
isn't a candidate for that. She's a candidate for a lot of other things. But she wouldn't be a candidate. That wouldn't be the place to start for her.
Yeah. Yeah. And so I think, I mean, at least for me, it's not a no, it's a not yet.
Not yet.
So
Exactly.
I don't have a lot of people who I'm like definitively saying no to, but I do have people that I'm saying not yet.
Hmm.
You're not ready.
Hmm.
Um, but when do you think people should start thinking about this?
I think we should start having the conversation, at least start having the conversation to figure it out, is in perimenopause when you start to experience symptoms. I know that a lot of doctors are going to tell you not to test. It's just symptom driven. That's how we clinically, start somebody on HRT. Because in perimenopause, testing can be a little bit challenging, especially for someone who doesn't understand the nuances of hormones shifting in perimenopause. So I would say that the second you start really noticing symptoms that are disrupting your life, that are causing you to not feel like yourself anymore, it's worth having the conversation about HRT and seeing if it is the right fit for you, and if it would work with all the different lifestyle changes that you are implementing. Yeah.
Yeah.
I don't think we need to wait until you're not having a period. I don't think we need to wait until we officially know you're in menopause. I think that that's a little too late. At that
Yeah.
point, we're at a low hormone state.
Yeah. And a lot of people are saying those things just to kick the can down the road,
Mhm.
right? Because they don't know what to do with that patient anyway. And so it's the same advice that they're getting when their blood sugar starts to creep up, right? Like, just wait, you're not diabetic yet, right?
Yeah,
It's
one
that
of
same
the
messaging.
Yeah, one of the issues that I had heard come up that I just feel we can mitigate. So I was talking to another friend of mine, and he was saying, why doctors have some fear or reservations around HRT and perimenopause is that in perimenopause, although a woman could be symptomatic, she also has the ability to be pregnant. She could get pregnant. And I was like, okay. And he's like, we don't really know exactly what would happen if a woman is pregnant and she's on HRT, and what are the implications of that. And I'm like, I understand. I think it's why the conversation is necessary. For example, I'm 45, I'll be 46 in a week, and there's no chance I'm getting pregnant. Let's just say that. And so I could easily have that conversation with my doctor and say, hey, that's not a concern for me. We can talk to women about, what are some of the other options for contraception, if HRT is the better option for you, instead of hormonal birth control. Because a lot of women don't want to be on hormonal birth control for symptom management, but they are also concerned, especially if you're in early perimenopause and you're still cycling, and goodness knows follicular stimulating hormone and luteinizing hormone are just trying to prod those ovaries to crank eggs towards the end. We can have a nuanced conversation about what that can look like for you.
Yeah, it's true. And also, well, I'm really struggling to understand what the concern would be if you're on bioidentical hormones and you got pregnant. Because I don't think there would be very much of an issue.
I didn't think so either. It was really interesting that was kind of one of the reservations. I mean, I just kind of a little bit of a backstory on me. I waited until I was 40 years old. I remember I was going to start trying to conceive at 38, but then I tested for Hashimoto's thyroiditis, and I decided to take a whole year to clean everything up. So I waited till I was 39. Finally, I think I got pregnant right at 40. after I gave myself a year to get everything in line. And we were looking at labs. We were looking at serum progesterone labs. We were looking at Dutch labs. I was kind of looking at all the things. And progesterone, I remember growing up, my mom used to tell us that, the women in my family, we didn't have robust progesterone levels. And I don't exactly know where she gets this. It's so funny how these things just carry
Yeah,
down the line.
how would she even know?
Well, she was testing for it in her she was really, again, she was having some of these symptoms in her late 30s that kept getting gaslit. And I think maybe a doctor did run her progesterone levels and were like, hey, you're really low,
That was
even in
pretty
her 30s.
forward thinking.
But didn't give her any progesterone, like just told her it was like, well, it's low.
Yes.
And so then my mom, it tells me, she's like, by the time you're in your 30s, you're not going to have any progesterone. So this was kind of the narrative that I was thinking about. And it's so interesting that, I always want to be thinking, well, why? And I think, there's trauma that's been through the family line and a couple of different things that can impact progesterone levels. But I remember thinking, I need to make sure I'm looking at my progesterone levels, especially at 40 years old, if I am trying to get pregnant. A couple of my friends and providers that I was working with decided that I was probably okay. I get pregnant. I lose that baby. I have a miscarriage about 5 weeks in, 6 weeks in. And I can't tell you if it was my low progesterone levels or not. I don't know if it was a genetic issue, but what I will tell you is that we got me on progesterone immediately after that.
Yeah.
And I stayed on progesterone. I got pregnant again in like 3 months later, 2.5 months later, I got pregnant with my son, Kingston. And at that point, I was on 100 milligrams compounded oral micronized progesterone.
Yeah.
And I stayed on that until week 17, give or take. So almost into my basically second trimester, I stayed on that. And so that is bioidentical hormone replacement therapy.
Hello, my beautiful listeners. I'm taking a quick break here to share something truly transformative with you today. If you're ready to take control of your breast health journey, then you need to get your hands on a copy of my book, The Smart Woman's Guide to Breast Cancer. I wrote this book to make a massive impact in the world of breast cancer, empowering women everywhere to make informed choices and educated decisions. You have so much more power and control over your health than you might think. And this is a roadmap to harnessing that power. Inside, you'll uncover the truth about conventional treatments. They're often overestimated benefits and underestimated, underexplained, and underdisclosed long-term side effects. But more importantly, you'll discover the true drivers of health and how the choices you make at home every day can lead you to the best health, the breast health of your life, even after a breast cancer diagnosis. Whether you're looking to prevent a diagnosis, avoid recurrence, or simply live your healthiest life, this book is for you. Join me on this journey to empowerment and health. Grab your copy of The Smart Woman's Guide to Breast Cancer today, and let's revolutionize the way that we approach breast health together. And quite frankly, I mean, so many of the early pregnancy losses are due to low progesterone.
Yeah.
And the conversation
It wasn't worth not getting on it. I was like, I need it. Let me at least check that box so that I have enough to maintain this pregnancy.
Yes. And it is astounding to me that this is not realized, right? And how the person that would be concerned about putting a perimenopausal woman on HRT because they're worried, what if she gets pregnant? They don't understand hormones.
Yes, yes. Well, and this is what providers are. This is the argument. So I remember I was talking, I was like, the one, this doesn't make sense. This isn't oral birth control that we're talking about.
Yeah.
These are real hormones that are identical to our body. So yes. I was confused, but these are one of the arguments for why women shouldn't be on bioidentical hormone replacement therapy in perimenopause. And I wanted to bring it up because I wanted to just address this. I know that providers and practitioners are listening as well. And again, if you're worried, have the conversation, but there really shouldn't be worry anyway. If anything, you know, when women get pregnant on birth control, they do. And we don't seem to have an issue, or that's not stopping us from prescribing that.
Right. 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 Although we should stop prescribing that, but
Yes, that's a
that's
whole
a
other
talk for another
conversation.
day. Yeah. Um, so most women also don't understand, and providers, unfortunately, don't understand how the progression of perimenopause is happening.
Yes.
And we're really not early on in your 30s, we are in fact losing progesterone,
Yes, we
right?
are. I
Like
mean,
that's the first
yes,
thing to fall off.
yes,
And
yes.
so you what word do you
I would be
use?
that woman. My mother too, obviously, and so
Wait,
is my sister.
you use a a term to describe your mother's cycles that really stuck with me. I forget what it was.
Mm.
Something periods.
Oh, nightmare.
Crime scene
Crime
periods.
scene periods, crime scene periods,
Yes.
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 That wasn't
And
until late perimenopause, though. Note that often we're not seeing crime scene periods until estrogen really isn't showing up and then shows up and then doesn't, and so we build up this endometrium
but
layer.
that's a progesterone
It
deficiency.
is,
Crime
absolutely.
scene
It's been a
periods are a
progesterone.
progesterone
Yeah.
deficiency.
Well, progesterone
Um,
deficiency, and then we see these big surges of estrogen.
yeah,
But
yeah,
yeah, the progesterone, she had left the party years ago, as far as I'm concerned at
yeah,
this point. Yeah.
yeah. Um, but what do you, how do you generally approach this window with women, and what is your approach to replacing them? Because I would imagine that it's, by the time they come to me, they're full on menopausal, either because they've already gone through menopause before they got their diagnosis, or they've been
Mhm.
rendered menopausal by their breast cancer treatment. So for
Right.
me, like when I'm starting off with everything. Like I'm starting off with estrogen and progesterone and testosterone and DHEA, because they have barely measurable levels. But that's not the perimenopausal woman. The
Mm-mm.
perimenopausal woman generally looks different.
Yes, very much so. So late reproductive age is going to be after the age of 35. And again, we do know that we're going to start having an ovulatory cycle, or ovulation isn't going to be as robust. We only have so many eggs left at this
Yeah.
point. And so
Yeah.
what women will start to notice is really a cyclical symptoms. So in the luteal phase, progesterone just isn't where she needs to be. Could still be there 100%, but just isn't as robust. And so a lot of what I'll see in women in their mid to late 30s is symptoms of low progesterone, but also symptoms of unopposed estrogen. So they'll notice that they're having a little bit of their, what they'll notice is less stress tolerance, less ability to multitask. Like, back in in your even early to mid 30s, you could still have all the tabs up. And man, just be working those tabs. Like you could handle
Mm-hmm.
all of it. But all of a
Mm-hmm.
sudden you're like, whoa, this is requiring more intention. I'm having to like actually think about this a little bit more. Workout recovery could be changing. PMS symptoms, instead of being 2 days or 3 days, now we're looking at 4 or 5 days. Again, it's a subtle shift and it's often dismissed even by ourselves because we don't know what's going on. Women may notice more tender, more heavier breasts heading into the end of their luteal phase. Maybe periods are a little bit more heavy day one, but then kind of peter off after that. And so, again, this is not often when a doctor is going to give them anything. But if symptoms, I would say intense enough, they're disruptive enough, like oral micronized progesterone, even I see more women every day being prescribed oral micronized progesterone, even in their 30s. Because when you run labs, it's very obvious that even on day 21 or day 19 or day 20 or whatever that 7 days after ovulation or 7 days before your period is, you're noticing that that number isn't optimal. I
Yeah.
would say almost every friend of mine who is in her late 30s is on oral micronized progesterone right now.
Now, are you just doing that for the luteal phase? Like, are you having women
Cycling,
take that
yes.
days 14 to 20, whatever, 7, 8, wherever their
Yes.
cycle
So,
ends.
and ideally, I would, in an ideal scenario, if I'm working with a patient, I want you tracking your cycle. That is your monthly report card. Are you ovulating? Did we have an ovulatory month or not? And so, yes, after ovulation, ideally you're tracking that. You're looking at basal temperature, or at least you're kind of looking for the signs of ovulation, and then you
Hmm.
start progesterone after that, and you kind of write it for 13 days, give or take, I would say. So
Yeah.
yeah, I'm absolutely recommending to cycle progesterone in perimenopause, particularly late reproductive or early peri. Late perimenopause, things get a little bit more wonky and inconsistent, and there's still, I mean, there's a lot of argument. I mean, this is where are we still cycling progesterone at this point? And I really, it's a conversation with the patient. I there's a lot of providers that are just going to offer static dosing. So you once you have inconsistent periods, or you're skipping periods more than 60 days, which is technically late perimenopause, and now it's all just a blur of symptoms. There's no kind of, you're still good in the follicular phase, but now it's hot garbage in the luteal phase. It all just starts to blur together. I always say that when you stop noticing that estrogen peak on day 11-ish, like, we're looking for a new level of care at that point. But
Hmm.
this is often when providers are saying, hey, you can just take progesterone continuously.
Yeah. For me, it's been very individual.
Yes, I was going to say
Um,
the same thing.
and because as women, like even my women who had chemotherapy and then, after a prescribed period of time, they stopped taking the ovarian suppression and their cycles come back. Um, and then you give them some progesterone to support them in the luteal phase. But then, a few months go by and they're like, listen, I feel so good when I'm taking my progesterone. And I feel like I'm going to use your term, hot garbage, when I'm
On the
not
other
taking
side.
it.
Yes.
And then I'm like, okay, so let's
Yeah.
take it. I do still try to cycle them. So I do try to give them like less during the follicular phase than I do during the luteal phase because I am trying to still maintain some level of physiology. Um, and then, when they stop having their cycle, then I just do it straight through. I do have them, all my women, I have them taking a monthly break, just like a 2, 3 day clean out, not long enough to bring on symptoms. I always tell people if you get symptoms after 3 days, break for two. If you get symptoms after 4 days, break for three, just to give them some opportunity to clean out their receptors and things like that. But I totally get it that when they have that protection of progesterone, which is like our hormone, right? It's our breathe a sigh of relief. It's our anti-anxiety hormone. It's our sleep hormone. It's our like ability to deal with the stressors of life hormone, right? And when
Yes.
you take that away, we miss it.
Yeah, we do. Absolutely. And even, for me, even within that luteal phase, I am often rhythmically dosing progesterone. And so I will start with 100. I may move all the way up to 3 and then come on back down to 100. What I learned initially, I was taking 2 to 3 consistently throughout that part of the cycle. I would just fall off a cliff when I would stop taking it. And I was like, this isn't it.
Yeah.
Like, I'm not going from
Yeah. This
200
isn't it.
milligrams. I'm
Yeah.
like, this is awful. Like, I don't want
Yeah.
to feel terrible for 3 days while my body's like, what did you just do to me?
Yeah.
And so again, it's very individually tailored, very nuanced, but that's why it's so important to really be listening to your own body. Like, what is working for you? And so for me, taking a static dose, or of 200 milligrams across that entire luteal phase, especially towards the end, isn't the best move for me. So I tend to bring myself back down before I stop taking it.
Yeah. And that makes a lot of sense, right?
Mhm.
It makes a
Yeah.
lot of sense. So,
It just
and
depends on your sensitivity, you know?
yeah,
And Like I said, my mom really struggled with the mental health aspect. My symptoms haven't been anywhere near as intense as my mother's, and there's a lot of things that I've brought in to manage that. I think she just didn't know a lot of the self care and the regulation strategies as well that she could have implemented. She was still going pretty full force without a lot of breaks, and she didn't have progesterone, like that was never offered to her.
Yeah.
She got an SSRI, and it made her more crazy. And so I in watching that unfold for her, I knew that not only did I need the hormones, but also that I needed other strategies in place as well to support me. And so,
Yeah.
again, it's really back to that conversation of yes and, because some women are going to be more sensitive to hormones or less sensitive to them, and it's really going to depend on on an individual basis what is going to work for you.
Yeah. And also, for a lot of women, unfortunately, they're going to have to educate their providers because
Yes.
when I started to go through it, I was not educated myself. This was before because I was very much in the school of hormones cause breast cancer and we shouldn't be using hormone replacement. It's dangerous. That's the system I came up in. And so when I started to go through it, I didn't even recognize the symptoms myself. And I got sent on wild goose chase after wild goose chase. I mean,
Yeah.
I had dizziness where I would be in the operating room and have to go sit down. And so what happened? Of course, they send me to a neurologist, and I have a huge neurological workup that's negative, 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 right? And then I was having
I was
palpitations.
going to say, yeah. Mhm.
So what happens? Of course, I have a huge cardiac workup that's
Which
negative, negative,
I'm
negative.
grateful. I mean, I think women are not having big cardiovascular workups in general. So, I mean, it is overkill because they kept getting it wrong. But I also want to advocate for women getting cardiovascular workups.
Oh, as well they should, right? It's not wrong, but the
But they
problem
need
is
them
at
both.
the end
Yeah,
of my negative workup, nowhere did someone say to me,
it could be
"Oh,
your hormones.
this
Yeah,
is this is hormone
yeah,
deficiency." Right?
absolutely,
No,
absolutely.
nowhere was that ever suggested.
Hmm.
It was like, okay, I guess you just have palpitations, like deal with it, right?
Yeah,
Take this beta blocker. And for someone who is normotensive, you take a beta blocker, you feel like shit. And my baseline heart rate is already in the 50s. So I did
that's
not
low.
feel
Yeah,
good on a beta blocker. I felt
no.
worse on a beta blocker. And then my eyesight was crazy. Now, I've been wearing contacts since medical school, but suddenly, before you operate on anyone, you have to read through their name, their medical record number, their diagnosis, what side you're doing, or the
Yeah,
consent signed, all of this. And like the operating doctor has to read these things. And I can no longer read the medical record numbers. Like by the time I got to the middle of it, I couldn't see anymore, and I couldn't I couldn't make a distinction between the number I just read and the number I was going to read. And this is, I'm 20 years into my surgical career. Like I didn't have a problem reading numbers. And all of a sudden, I couldn't read this string of numbers. And I kept going to my eye doctor and saying, like, I can't see. How can I be a surgeon and I can't see? And he's like, where are you having problems? And I said, I can't read the medical record number. I'm fine in the operating room, but I can't read the medical record number. And he's like, your prescription hasn't changed. You're fine. You're fine. You're fine. It's not that you can't see. And it was that my brain was like scrambled
hmm,
and I couldn't
mm.
make sense of this string of numbers. And, again, like back to the neurologist, and the eye doctor sends me back to the neurologist, and the neurologist is like, you're fine. I can't find anything wrong with you. Right. And it becomes like not for a lack of looking, right? They look everywhere, and nowhere did anyone say, you're just going through menopause. Right.
Yeah, it's
You're just
hormone.
in
You
it.
mean your master CEO stopped showing up?
Yes.
to the
Yes.
conversation, to the
That bitch
brain
stopped coming to
conversation.
work.
Yes.
Really pissed me off.
No, and here's the thing. We up until Dr. Mosconi's work, we didn't have scans. We didn't have scans on women in menopause and perimenopause. We weren't connecting the dots. We obviously knew that women had less protection against Alzheimer's and dementia in menopause. So we knew that that had to be an independent risk factor, but we didn't know why. And because we didn't have the data, we didn't have the visuals, we couldn't put it together. And so, yeah, it's amazing to me. Again, 80% of your perimenopause symptoms are going to be brain related, including your sight, including your vision. That's your brain.
Yeah.
The itchy ears, brain, all of that.
Yeah. Yeah.
And again, hot flashes and night sweats. I think women think that those aren't brain related. They're 100% brain related.
Yeah. Yeah, absolutely. Because that's our thermoregulation center.
Thermoregulation. Yeah.
Yeah. So what do you think about the whole sentiment that like, well, if you're already through it, it's too late?
No. No.
So is it ever too late?
I don't think so. I mean, even with the Women's Health Initiative, they're, when they looked 20 years out, if they looked at the data, so a woman, let's say she's in her 70s, we saw a tiny, like almost minuscule increased risk with CEEs, conjugated equine estrogen, and potential stroke. And we're talking about receptor sites that haven't been used in decades.
Yeah.
And again, it was almost imperceptible in terms of a risk. So no,
But
I think
I have to say that risk in every decade, as far as I'm concerned, is attributed to oral estrogen, which I am not ever a fan of. Because
we're talking about an oral conjugated equine estrogen. So one, it's not a bioidentical estrogen. Also, it's an oral pill. So it's going to the first pass with the liver and the gut. It's a different conversation when we're talking about transdermal. Absolutely. I just wanted to report, like, even in that scenario, that again, the risk doesn't outweigh the benefit.
Yeah. Yeah. And I think it's important to note that even in that scenario with conjugated equine estrogens, when you look at the group that took them alone without the progestogens, they had a 23% or 24% reduction in breast cancer.
In all, and in all cause mortality.
Yeah. Yeah. So,
with just the conjugated equine estrogen, not the progestogen, not the NPA.
Right. Yeah. Right. So even with the increased risk that you might have in taking that form in an oral form.
It wasn't affecting breast cancer risk, and it wasn't affecting all-cause mortality. So again, I just wanted to mention, and even still, and again, there's a lot of women who, now they're 60s, they're in their 60s and their 70s. They're the generation of the Women's Health Initiative where they're like, can I still get on hormones? That's the generations we're talking about right now. But currently, I want to say that the window of opportunity is going to be before hormones are bottoming out to begin with. We don't, a lot of doctors are going to argue that we don't have a lot of evidence of women getting on hormone replacement therapy in perimenopause or even late perimenopause, but that is changing. And I would say your window of intervention is before you're in a low hormone state.
Well, also, I mean, we may not have the data, but that is not stopping women from going out there and getting it. And they are finding over-the-counter sources of progesterone because they know that it's making them feel better.
Yeah. And
so women are going out and getting it.
Yes, that dosage is, I think the highest you can find is 50 milligrams, but it's going to be topically applied. Again, this is a big molecule. I mean, if any relief, I'm grateful for. And yeah, women are very, I mean, believe me, women are very good about getting what they need. But yeah, I mean, we need to do better than that, than women. And not always, unfortunately, are all these products bioidentical progesterone either. So, but
they're not, and they're not all clean.
They're not all clean. Yeah.
Which is another issue that I have with them. Mm-hmm. So how do you think we solve this problem?
I think we solve this problem A couple of ways. One, we keep having these conversations, so more women are hearing it. Because the reason why perimenopause is having a moment, it isn't because of the providers. It isn't because of the healthcare system. It's because women are demanding better. Women are advocating harder. They are asking their providers, could this be perimenopause? Can you support me in perimenopause? Like they're like, I think that this is perimenopause. It's the consumer outrage that we are seeing this movement happen. So these conversations need to happen. More courses that are teaching providers how to prescribe hormone replacement therapy needs to be out there. And I mean, at the end of the day, medical school curriculum needs to include it again.
Yeah. Yeah, absolutely. And
Yeah.
that has to happen.
Yeah.
It has to
Or
happen in the
we're not going to see
medical
it. Yeah.
school curriculums. It has to happen in all of the
Residency. Yeah.
health professional,
Mm-hmm.
right?
Yeah, and
Okay.
all health
And
professionals
in the
need to be
meantime,
educated.
your book is out there as a
Yes,
resource.
yes, yes. There's a
So
whole
tell
chapter on
people about
HRT.
how they can get that.
Yes, so you can go, it's available everywhere books are sold. And if you're like me and you're a midlife mom who, you consume content during pickup and drop off, like that was me today. I did record it to Audible or audio, so it's going to be available for audio as well. I do recommend having
Amazing.
both. The book is going to be found on Amazon, Barnes and Noble, anywhere books are sold, and on Audible as well. But you can go to drmariza.com. So that's drmariza.com/book, and you will see it there. And I have a slew of beautiful bonuses, including a perimenopause revolution masterclass where I'm covering hormone replacement therapy so that you feel educated enough to have the conversation and to ask the questions. I have recipes, meal plans, workout videos, exercise snack videos, a symptom tracker, cycle tracker, functional lab ranges, what to ask your doctor in terms of labs. All of that is in the toolkit, the Perimenopause Power Toolkit. So while you're waiting for the book, if you're getting it pre-order, even a week pre-order, I want you to know that I've given you everything to get started literally today. So that in the next 7 to 10 days, if you implement just a few of those things, you will start to feel like a different woman. You will begin to start feeling like yourself again. So that is all included, so that you are set up to win.
Amazing. I'm so looking forward to this book. And I think that all of those things that you talked about and just setting the stage for receiving the benefits of hormones is so important, and you're providing everyone that service. So thank you so much. This was an awesome conversation. I know people are just going to eat it up. And I know that we have a lot of great conversations ahead of us too. But it was so wonderful to have you on today. Everyone, make sure that you pick up the Perimenopause Revolution, and you can get it on Dr. Mariza's website or anywhere where you buy your books. And if you are worried about breast cancer, or if you know anyone with a breast cancer diagnosis, or if you just want to know how to prevent breast cancer and how your hormones speak around breast cancer, make sure you pick up a copy of my book as well, The Smart Woman's Guide to Breast Cancer. It was so wonderful to see you today. Thank you so much for joining me.
Thank you, Jen, honey. It was such a pleasure.
And everyone out there, if you like this, please send us a comment, share it with someone who needs to hear it, and know that I will be back next week, same time, same place. It's Dr. Jenn. Bye for now.